All right, thank you, everyone. Good morning and welcome to Discussions in Diagnosis once again. I'm Goutham Rao. I'm the director of the UH Advanced Center here at University Hospitals. And today we have a very special guest, Dr. Riley Grosso, who is Director of Quality and Peer Review for the Department of Emergency Medicine. And more importantly, she's going to discuss the really challenging problem of abdominal pain in the acute hospital setting. Now, this is a challenging problem, I think, across many different disciplines, including primary care in the ambulatory setting, which is what I mostly deal with. Also among children, it's extremely challenging to make a diagnosis. And Riley and I were going back and forth a little bit prior to this discussion about the lack of guidance. And that's one of the major objectives of mine. And it's something I've worked on as well. In other words, developing best practices for diagnosis of abdominal pain. So welcome, Riley. Thanks for joining us this morning.
Thanks so much for having me. I agree. Just as a commentary, I agree. I think abdominal pain is one of the most difficult diagnostic kind of areas in the body, especially when it comes to pain presentations. I think we all know literally there's just a lot that can go wrong in the abdomen, and they all can present subtly but similarly, especially in both adults and kids. I think there's been a lot more time spent on the kids' side trying to prevent the use of CT scans. So there's a lot more decision rules for kids. The decision rules for adults almost don't exist, which help. There's really not a lot of objective decision rules you can use in abdominal pain, which makes it a tough thing to both diagnose and also teach how to diagnose. It's a very subtle presentation. So I agree. It's a tough one.
Okay, thank you, Riley. So let's plunge right into the discussion, and thanks for that commentary. So let's say we have a patient, and he's a typical patient in the sense he's a 43-year-old man. He has a history of mild intermittent asthma, not too serious. He smokes a pack a day, and he's had mild gastroesophageal reflux disease for several years. Presents to the emergency room with increasingly severe abdominal pain of 2 days duration. He had actually been to an urgent care center a day earlier where they did a history and physical exam, and then he was discharged just with a recommendation to take antacids, which did not help. The pain is rather diffuse in location, somewhat sharp in quality. He has no associated nausea, vomiting, diarrhea, no stool changes, no urinary symptoms. He doesn't drink alcohol, doesn't use illicit substances, takes no medications, and just has the reflux, which is mild. So, I'm sure you've encountered patients like this as well. Where would you get started? How would you approach this?
I think just like most diagnoses, I think it's all in the history and physicals, especially in abdominal pain for me. I think getting a sense of what the crescendo of the pain has been like over the last 2 days. Did he go to urgent care and then all of a sudden things got worse and it's been bad? Did it plateau for 2 days, or has it consistently gotten worse? The questions of what makes it better, what makes it worse. Does he eat and it's excruciating? Does he eat and it's a little bit better? The lack of other associated symptoms is a little odd in this case for me. When I read the case that you sent me, that's something that stuck out to me, is that he doesn't have any associated vomiting or diarrhea, which, makes it harder to call it something a little more benign. I think with the history of gastroesophageal reflux, it's easy to anchor on something in his stomach, but his exam is key. I think for me in abdominal pain, focal exams are always way more concerning to me, especially in the right patient population, than something diffuse, especially if it's been diffuse for 2 days and still hasn't localized. The diffuse that then localizes is a classic, appendicitis, or, I have something general and now I have peritoneal signs in one area type of presentation. But in someone who's staying diffuse, that's a little less concerning for something like acutely surgical. It would be hard without pushing on his belly to know if it's diffuse and peritoneal because he perfed something, or is it just diffusely kind of not feeling well? So it's all in the history and physical for me with him to decide, really. I think the ultimate conversation here is a lot of the decisions we're making in abdominal pain are we imaging or not, right? Because our imaging for abdominal pain is pretty good. CT and ultrasound are both pretty good at picking up a lot of the pathology that we really need to pick up, especially in the acute setting. I think in the primary care setting, I would imagine imaging is not quite as high yield because of the more chronic disease processes that are showing up. but, they pick up most surgical problems. It's going to pick up, any like perforations or acute abscesses or even nephrolithiasis I've seen present like this with that diffuse abdominal pain that doesn't localize. So the question is, does he need a scan or not? And he was 44, so he's a little
43,
older,
yeah.
but not old enough that I would put him in I have a group of humans who I think of as like, you have to talk me out of a CT scan in a group of people. And that group includes people over the age of 65, because there's been studies that say that they present more often with surgical complaints. If they're going to present with abdominal pain, they're going to present with something that is going to need at least hospitalization, if not surgery, more often than their below 65 counterparts. So that's something that I can't miss. I can't send somebody home with a surgical emergency, right? I can miss viral gastroenteritis. Technically, it's not great for the patient, but it isn't harmful. Maybe symptomatically, but I can't miss a small bowel obstruction. I can't miss like perf diverticulitis. So over 65 for me is you got to talk me out of your CT scan. You got to tell me everything's totally fine. I was kidding about my abdominal pain. I'm going to go home now. And then the immune suppressed population is another population that I'm very quick to scan. And he's neither of those things. So he, for me, this case is really about, when I push on his abdomen, does it seem like something's wrong, or is he just having the complaint of pain? And that's tough because culturally people handle pain differently. And people like stoicism is the thing that really throws me off with abdominal pain. I've had people with abdominal disasters who are insanely stoic. So for me, he's on his second presentation, and this is an anecdote, but I've always been taught on second presentations, you have to consider a bigger, more expensive test. At least like he represented, something's still wrong. So I think he would probably end up in some sort of imaging, depending on his exam. So if he has a focal exam in the right upper quadrant, maybe an ultrasound, or if he has a renal exam, then probably a renal ultrasound, but if not, a CT scan likely.
So to understand you correctly, let's say the physical exam is completely normal. He's non-tender, he has normal bowel sounds, no distension, nothing. Would you still image him or not?
No, probably not.
No, okay.
If his exam was completely benign, I do rely on my exam for abdominal pain pretty heavily. And even stoic people, like they tend to flinch when you push on the thing that's swelling or inflamed or hurting. And so I think he has a disease process that could definitely explain some of his symptoms with having, an ulcer or something like that. So if his history fits that, I think a discussion with the patient saying, we could get a CT scan, but I'm not going to find these 5 things that I think we need to find today. Let's try some of these medications and have you return if something bad happens, and give him good return precautions. If his exam is completely benign, that would be my thought.
So on that front, diagnosis is now considered to be a shared decision-making process. Let's say you've got a benign exam, he's feeling worse, you don't find anything. What instructions would you give him specifically?
So I think localization of pain, like your pain's kind of everywhere. If it goes to one spot, that would be very concerning to me. If you start to have associated symptoms like, if you start to have associated symptoms like vomiting, like diarrhea, like fever, if you start to feel like you can't really catch your breath, which the other thing is I probably get labs in this guy because I always put things like DKA and like other kind of truly non-abdominal diagnoses on my differential. So I'd probably do at least basic labs on this guy, including a lipase, because that could help me a little bit without having to image him. If his labs are totally benign and I can get him feeling better, that's the other thing. I don't think I would send him home if nothing I did was making him feel better. I think that's another conversation with him about a CT scan. Like my suspicion's still low, but I can't make you feel better with the normal things, which is concerning to me because they usually work. I think now we should CT scan you is a conversation I have with people who just aren't getting better with my kind of, normal, I have an ulcer like complaints, and that type of thing. But return precautions for him would be localization, associated symptoms, honestly, just not feeling better in a few days. Like I don't want you, just because I didn't find anything this time doesn't mean I'm not going to find something next time. So please don't ignore it if it doesn't go away. And then obviously pretty close follow-up with a PCP or GI, depending on the availability of those things.
Yeah, so I think your commentary, which is spot on, I think touches a couple of really fundamental issues. One is that abdominal pain is often an evolving diagnosis. So he might be discharged and something might show up, even though he's had it for a couple of days already. But It also, you've also hit on the fact that we don't have great guidance. I mean, it's a lot of judgment. Should I get a CT scan or not? One of your colleagues might decide to do that and others won't. And they could both be correct about it. So,
Oh, I have colleagues that would scan this every single
yeah,
time.
absolutely.
Yep. Abdominal pain in someone who's representing, they wouldn't think much about it, to be 100% honest. And I don't fault them for that. Because I think we do find things. I'm sorry, I saw a question in the chat.
Yeah, we'll get to questions later. But let's talk a little bit, let's change gears a little bit. What do you think, sort of on a population level, are some of the biggest challenges in making a diagnosis of abdominal pain? Why is this so hard?
I think the description of abdominal pain is difficult, and it's not classically consistent. So, we learn in chest pain, for example, like that crushing, pain that radiates to the back is concerning for your aorta. Like there's some in abdominal pain, there's some guidance, like some things get better with food, some don't, some radiate to your back, like pancreatitis. But in general, like belly pain isn't well taught in the way that it's described. So, when you sent that case, it said like sharp and diffuse. And that's the words patients use, but I in med school was not taught to associate sharp and diffuse with any one disease process. In med school, I was taught to, thunderclack headache, that's a disease process. Like neck stiffness, that's a disease process. But in your belly, there's not like one word that we use that kind of triggers a cascade, like cognitively in my brain. I think the heuristics of your belly are hard. Like I'm 7 years into being attending. So I've been doing this for 11 years, and the heuristics of abdominal pain are still not something I could draw out for one of my residents. No. Whereas the heuristics for chest pain, a little bit more, because we have more decision rules and more clear. We've studied like 1 million people with MIs, and we know how they present. I think people who have diverticulitis or peptic ulcer disease, like they present so less specifically that it makes it particularly tough, I think.
Yeah, and it touches upon a broader issue, and that's cultural sensitivity and how we approach abdominal pain. So the classic descriptions of chest pain, somebody sitting on my chest, I think it was largely derived from an older white male presenting with those types of symptoms. And who knows how different types of people describe their abdominal pain. So sometimes the history can be so variable that it's very difficult for us to pinpoint a diagnosis. What other challenges do you think we face?
We haven't really touched on kids, but for kids, the concept of nausea is really hard to get from like that middle-aged, like 3 to 8-year-old, like,
yes.
And often nausea is pain is nausea. It's really hard to differentiate the two. So I find abdominal pain in kids to be particularly challenging to like nail down. For an adult, I can say like use one word or point to with one hand to where it hurts. And you do that to a kid and they point to their whole abdomen. And they're not wrong, right? They're the patient, they're right, but it's just difficult to help discern that. And I also, honestly, for kids, getting what they feel from what their parents sense that they feel is very difficult sometimes. Like I have a lot of trouble, especially with the slightly older ones, of parents trying to, like, they grimace when this happens. And so when I say, oh, when that happened, did it hurt more? And the kid's like, no, because they don't necessarily have the words. So I think kids are another challenging area for diagnosis in abdominal pain. And just the referral of pain, I think we talk a lot about in younger kids, especially in males, like we classically miss torsion because they don't say, a 13-year-old is not going to tell you that his testicles hurt, right? He's going to say my belly hurts, which it does, but he's not going to let in on information. So I think some of the challenges of kids is the history taking is a little difficult. They don't have the words that a lot of adults have to say, I'm nauseous, like I feel like I'm going to throw up, those type of things. They just feel that their stomach hurts. Like my stomach hurts is a good word.
Even the exams, I think, in my experience, can be somewhat equivocal. They've got tenderness everywhere, or they have no tenderness at all. It's just very difficult to figure out where the pain is coming from, I think, in a child. Especially,
and you have to get over the like fear of being at the doctor for a lot of these kids too, right? Like I'm a scary person when I walk in that room. So of course your belly's going to tense up and do this when I try to examine you. So unless you have the time and a lot of patients. Like I often have parents examine kids like that. Like I'll have mom push on bellies for me, and just watch the kids. Like, and the kid who grimaces when mom pushes on his belly, like that's a kid I'm very worried about, because that kid is very comfortable with mom touching his belly, obviously. And if there's something that is wrong and they grimace when they do it. So there's just like tips and tricks, but there's not like guidance, right? The Alvarado appendicitis score doesn't say like have mom examine the patient. There's none of that built into what we learn. It's tips and tricks you pick up over the years.
Okay, so let's change gears a little bit, because you're kind of heading in that direction anyway. And then what do you think we need as physicians to improve our diagnosis of abdominal pain and reduce the rate of misdiagnosis?
I mean, I'm a fan of decision rules in general. I think especially for younger physicians whose heuristics aren't built yet. So I think the development of accurate decision rules. I think for me, decision rules that help for the imaging decision is what is needed. I don't necessarily need a decision rule that alone picks up pancreatitis or alone picks up, cholelithiasis or symptomatic, a bile duct stone. I need stuff that tells me they're more likely to have badness in their stomach. So you should do the CT scan that Dr. Macias just like articulated what I was going to say, and that aren't without risk. Right.
Right.
So I think decision rules would be very helpful. I think you mentioned this, but I think also in medical school, we learn the abdomen in pieces, and the abdomen doesn't present in pieces, right? It doesn't present as a pancreas. It doesn't present as a gallbladder.
Mm-hmm.
So treating the presentation of abdominal pain a little more homogeneously when we teach it is something that probably needs to happen, instead of teaching this is how pancreases present, this is how appendicitis present, teaching this is what concerning abdomens feel and look like, this is what concerning symptoms feel and look like, and then we should go after that.
Yeah, that's a fundamental problem in diagnosis. So I'm trying to picture this decision rule. So we would input things such as a white count, the patient's age, temperature, plus minus tenderness, put those into a decision rule. And what it would spit out is, based upon the relative incidence of different pathologies of abdominal pain in the acute setting, imaging would be helpful. So it's conceivable that something like that could be assembled if we had a lot of population-based data. So that's helpful. So the next question I have for you is, do you take advantage routinely of any clinical decision aids or guidance that's available to you when you're evaluating abdominal pain?
For kids, yes. I think there's a bunch of different, there's the appendicitis score. There's a couple other ones in kids. I think, and Dr. Macias could jump in here, but I think the PCAR network is working on some appendicitis scores as well. And they're notoriously good at decision rules. And I think so peds, yes. Adults, I don't have much, honestly. No. I really don't have anything. I have my rules that I teach my residents, in that, those over 65 have statistically shown to have more surgical emergencies when they present with abdominal pain. They get admitted more often. We shouldn't miss those. And the immune suppressed population doesn't show you when their abdomens are disasters. So those on chemo can hide a perf, can hide the mesenteric ischemia, can hide all that stuff. But those aren't rules. Those are just things I've picked up over the years. Those are heuristics that someone helped me build that I found to be fairly reliable. And I think in any decision rule, they would probably pan out from the studies, but aren't specific decision rules.
Yeah, I think, one of the barriers to developing decision rules in adults is that everybody thinks that, adults are far more nuanced in terms of how they present. There's a wider range of pathology, a different course, different settings, et cetera. So it'd be hard to develop a single decision rule. And that's why a lot of people rely on their own clinical experience or develop their own heuristics as well. Whereas in children, I think you're right. There's been a concerted effort to really identify those that have abdominal pathology.
Yeah, I think Dr. Macias also brings up a good point. This isn't just for pediatrics, but I think, as you said at the beginning, the evolution of these disease processes is where you catch them is a difficult thing, and whether you catch them in their presentation is very different, right? The 1 hour, appendicitis looks different than the hour 12, than 24, as Dr. Macias said. I totally agree. And I think that comes with this doesn't prevent the representation. Sometimes I actually want them to represent, right? Like I've
Mhm.
said to moms before, this 100% could be appendicitis, but it's been going on for an hour. And I think if I image now, nothing's going to be there and we're going to send you home anyways. So why don't we save the imaging for 6 hours from now? If your kid looks worse or still is having these symptoms, these are what I want. You want me to come back and I want you to say these words to the triage nurse. And I will often write it out for them and say, like, I was here for appendicitis earlier. I'm feeling worse. I'm concerned I like have an evolving appendicitis. And it's easier with parents and kids than it is with adults, because adults sometimes hear, I don't know if sometimes I don't know if we're very good at a shared decision making with adults as we are with parents. And with adults, sometimes what I think they hear is the doctor said nothing was wrong, so I'm going to sit at home
Right.
and ignore this. And what I didn't say that, but that's what they hear, and that's still on me. I need them to hear, I can't find what's wrong right now because it's not evolved enough. It's going to evolve, and then I'm going to be able to see that. Then I'm going to be able to see it. So I want you to come back if it does evolve. And I've had that conversation with the case kids who come in with like very early appendicitis and call their parents and have that discussion,
Yeah,
but
sure.
it's not easy to have with everybody.
No, that's understandable. Okay, the final thing I wanted to talk about before we open up the discussion was an article I had sent to you about abdominal pain. It's from Switzerland, highly developed healthcare system, and a couple of surprises. One is that the rate of misdiagnosis was relatively low, 1 or 2%. But I think the more interesting thing, Riley, was the proportion of abdominal pain diagnoses which were extra abdominal, extra GI.
Yeah, that was
comment about
interesting
that
to
a
me
little
as
bit?
well. That stuck out. I think one thing that was interesting is they didn't include the urinary tract system in intra-abdominal. So they didn't include pylo, UTIs, or stones in the intra-abdominal. So I think, and if you look at the lists of diagnoses, those are on the top 5 or 10 of each of the age processes. So I think for me, I would have included those in an abdominal pathology. Like I think of, they included other retroperitoneal things like pancreatitis. So for me, that's a little bit high, but also I think it's a good reminder that, DKA, pneumonia, sepsis, like other things present. I've seen a lot of abdominal pain and pneumonia, especially it's a kid thing too, like lower lobe pneumonias presenting as abdominal pain. So I think it's a good reminder, but I wonder, I didn't redo the calculations or anything. I wonder what that percentage would look like if you included the urogenitary system in the abdominal pain.
Yeah, it would probably be a little bit lower. Okay, Riley, so we've got a number of comments. I'm going to try to get to these
Sure.
and then we'll open it up if we have a couple of minutes left. So Dr. Saeed is asking, should everyone with abdominal pain automatically receive imaging? And should there be an attempt to control symptoms, which is a good question. So
yeah, I always think that, that's part of my job as an emergency physician, is not just diagnosis, but truly symptom control. And I think if things respond to if what I think is an ulcer responds to the appropriate medications for an ulcer, that would be helpful for me to know. It's part of my decision-making process. I don't think everyone should automatically receive imaging. It's not without its consequences, especially not in just radiation, but in iatrogenic findings, and end up chasing your tail on something that isn't clinically significant. I think recurrence does play a role in the patient we talked about, especially if it's someone who, is someone who typically manages their pain and everything at home and can't, and so something's going on with him. You just need to figure out, is it something that you can do something about, or that a diagnosis would help? So I think reoccurrence plays a huge role in the patient that was presented, and the lack of being able to control his symptoms, but I don't think everyone should automatically receive imaging.
Great, thank you. So a couple of comments, one from Chuck Macias about CT scans and in children, and of course carrying their own risk. And there's a lot of work in this area, and that we do need better decision rules. The complexity of abdominal pain, at least in children, is that pediatric decision rules rarely capture the evolution of the presentation, which we discussed already. Dr. Saeed is talking about improving clinical skills, and there's a whole movement to improve clinical skills, not just among students and residents, but even among attending physicians based at Stanford. Abraham Verghese leads that out there, and I think it's definitely applicable. Can we pick up some subtle findings through our physical exam and history taking? So that's a good comment. Dr. Delansky, from your experience, please share any system vulnerabilities that stand in the way for making the diagnosis. This is really important, or system factors that are essential for accuracy of diagnosis. In other words,
Yes,
beyond the
errors in
clinician and
diagnosis
patient. Go
yeah,
ahead.
errors in diagnosis are I don't know if I could use the word often, but are related to external factors all the time. I mean, as I think when you say I want to take a good history and physical on every abdominal pain, and then I have 40 patients to see because of overcrowding, I think I think external factors play into how, if I had one patient who I could spend all the time in the world, and I'm not just saying this is to just emergency departments, primary care deals with this too, right? You have to move on to the next patient. I think you could get a lot more. I think cultural barriers and me not being taught how to speak the language, not just English, but like the literal like language of my patients. I use words they don't know. I assume health literacy that's higher than they have. Even if I understand their health literacy is low, lacking the words to use to get the right information out definitely is an external factor and a system vulnerability for sure. I think a lot of the misconceptions about people not being unwilling to admit to some of the risk factors, like alcohol use disorders would help me a lot in a lot of these diagnoses. Smoking would help me a lot in a lot of these diagnoses, and that type of things, and people not being willing to admit that kind of stuff definitely plays into the
Absolutely. Okay, thank you, Riley. Any final thoughts before we wrap up for this morning?
No, I mean, if anyone can figure this out, please let me know. I would love a decision rule or something to help with this. I think the abdomen is a mystery and something we struggle with a lot.
Yeah, I think this is the most challenging undifferentiated symptom that we have to deal with. And this is going to be a major focus of the UH Advanced Center over the next 3 or 4 years, both in children and in adults. And I see that Chuck has got a number of other comments. So I think we'll continue the conversation, Riley, with you and with others as we go through this. So thank you, everyone, for joining us this morning. Next week, Dr. J.J. Hughes is going to discuss the diagnosis of pancreatic cancer, which of course can present with or without pain. But I think stay tuned for that, and that will be on the 27th. Everyone have a wonderful day. Take care.
Thank you.